help me out. Yes. But your seminars that you put on out there, and it talked about pain management as a big portion of this intervention radiology.
That's right. Increasingly, interventional radiology has been able to offer a variety of pain treatment techniques, again using mostly X-ray guidance and sometimes CAT scan guidance to place, for instance, with spine problems. There are a number of problems, discs with joints that have become arthritic, and with fractures that occur, especially in older folks with compression fractures from osteoporosis. And we can, in a very minimally invasive way, place a small needle into the affected joint or near the disc that's causing a problem, and perform steroid injections in that way, or local anesthetic injections. We call them epidural blocks much of the time for some of the disc-related problems. Facet joints, which are the arthritic joints that affect many people and cause pain. And vertebroplasty is an area that's really grown and become a big help in treatment of older folks with compression fractures, whereas in the past 10 years ago, this was a technique not available, and people had to tough it out with pain medications and bed rest, and which led to other problems, and we can really eliminate that a lot of the time now.
Yeah. So what patients are candidates for you?
There's a whole array of patients or people with a variety of problems that we can help to take care of. On the pain front, which we were just talking about, people who have, especially older folks, who have compression fractures and who are taking pain medication, but really having a tough time getting by with their daily activities. And if their fracture is not healing rapidly enough, that's one area that we can take care of with a bone cement injection to help get rid of the pain and stabilize the fracture. Patients who aren't responding to regular anti-arthritic or pain medication therapy for arthritic problems in the back or disc problems with pinched nerves, we can offer a lot of relief for them with some of these injections. Patients with blood clots in their legs or in other places, both in arteries and veins, or cholesterol atherosclerotic blockages that are causing them pain in their legs when they walk. That's somebody who ought to see an interventional radiologist. And also women with fibroids. That's been an area of a lot of growth in the last 10 years. Those are just to name a few.
Yeah, it wasn't in my notes here about the women with fibroids. Explain what that is and what you're doing for that.
Okay. Fibroids are benign growths of the muscle in the uterine wall that affect almost half of women in the United States. Some of them may never have symptoms, but about a quarter to a third of women with fibroids will have symptoms and need treatment, and that's hundreds of thousands of women. And this problem can cause bleeding, it can cause pelvic pain, and a variety of other bulk-related symptoms because the uterus gets larger and presses on the structures around it. And uterine artery or uterine fibroid embolization is a technique we've been performing on an elective basis for almost 15 years now. And it provides minimally invasive relief by us guiding a catheter, small tube through the arteries to where the fibroids are, putting in some small particles that block off the blood flow. They make the fibroids shrink and die or scar down, and that relieves their symptoms the vast majority of the time. And this is done with a quarter or even less of the recovery time of a hysterectomy, less complications than with an open surgery, which is would be a hysterectomy, for instance, and also less pain. Patients after this procedure are back to their regular activities usually within 5 to 7 days, as opposed to 4 or 6 weeks.
Right. Are there candidates that are not good for the interventional radiology?
Yes. Certain situations in which, for instance, a cancer or something that must be removed in a larger way, or an area explored where a defined diagnosis can't just be made on the imaging, that kind of situation requires surgery. along the lines of women with fibroids, there's sometimes other problems going on that are causing bleeding or pain, and we can figure that out usually with the workup that we do, doing an MRI, and in concert with their OBGYN. Sometimes a biopsy is required to figure out if there's some other issue that's causing the pain, and in that situation they may not benefit from the embolization, but we can usually find those situations out.
You figure that out?
Yes.
Yeah, yeah. You talked about injecting different medicines and whatnot. Are you actually curing anything, or actually taking care of the problem, or is this just a step to help the patient, in relief of pain or whatnot?
Sure. It depends on the situation. With pain procedures, certainly with compression fractures, we're taking care of the pain and helping to stabilize the fracture, and the fracture will then generally heal. So we are generally definitively taking care of that problem. With more chronic issues like disc problems and with some of the arthritic problems, those kinds of pain procedures, there we're controlling the problem, and we can often control it for a long time just with one or a few procedures. But in those situations, some of their pain may return, but they may very well be candidates again to do something minimally invasive rather than have surgery. Situations with the fibroids, usually the fibroids don't grow back the vast majority of the time. So most of the time that's a definitive treatment too, but it does depend on the age of the patient, and those are sometimes issues that we need to discuss as to whether or not there might be a significant chance of recurrence of the fibroids. An area that we're treating also is cancer, and there are patients who don't respond to chemotherapy sometimes, or can't have surgery because of the location of their cancer. It may be too extensive, and in those situations we are helping them to decrease their pain from the cancer, and starting to show, some of the data is starting to show that we may be increasing their lifespan with certain kinds of cancer embolizations or with ablation of tumors.
So there are things that the interventional radiology will not be able to work on.
Yes, that's true. Yep.
Yep. And those include
areas that we wouldn't work on include, heart disease. Certainly the cardiologist, you'd go to a cardiologist for heart problems. Again, cancer that needs to be removed. Situations like that, be it in the pancreas or in the lung, many of those situations do need a surgical treatment first as the best option for the patient. And then sometimes we can offer a treatment if the patient is not a surgical candidate. Other situations would be really situations of a illness like a pneumonia or certain medical problems that don't require even a minimally invasive treatment, can be solved with medicine or some other kind of physical therapy, for instance. Also for certain kinds of medical or pain problems can really yield a very nice result without ever having to put a needle in anybody. So we certainly have that in mind, even with the minimally invasive nature of it. When there's a condition that doesn't need anything invasive, we try to avoid it.
Yeah. So you in interventional radiology, you're using most any orifice in the body, or are you strictly going through veins and arteries?
Most of the time, most of our procedures are done through an artery or vein, where we're guiding our catheter or a small tube by that route. But many of the procedures that we do, we go directly through the skin and through the tissues that are near the structure we're going to go into, without a preset path, like through the mouth or the esophagus for a endoscopy or a colonoscopy. For instance, if somebody has a kidney that's blocked and a urologist can't get out a kidney stone by going up through the ureter or through the bladder. We will directly puncture through the back under ultrasound and X-ray guidance and go into